Maybe these topics are very interesting. That's why, Dr. Sharma, you always keep them in the afternoon after lunch. Now to make sure everybody is awake and listen to the top advances of the valve. So, we all know very basic 4 valves, and once upon a time, all these 4 valves had to be taken care by surgery. But guess what? Over the last 15 years, things have changed, and they all can be done percutaneously, means through a small hole in the groin. So we deal with mostly the aortic, which is there, which actually first approved in 2011, subsequently mitral in 2013, and tricuspid as of last year. So we are going to go through all this, some important things. So before we get into what the advances have been, the guidelines have been changing, and what we learned when we were medical students is if you have valve problems, they got to be symptomatic. Some kind of symptoms have to be there. Subsequently, it went from symptomatic to asymptomatic, but severe valvular disease was what they had. From there, we are moving on to moderate to severe, which is called as progressive, with or without symptoms. So that is where we are. So we got to keep this in mind as we are going through this lecture. So the first will be what we have learned in the TAVR, which has been there. Like I said, I think the first trial came out in 2010, and approval happened in 2011. So there have been several trials between 2 valves that you see there. One is a balloon expandable valve on the top, and on the left corner is a self-expanding valve. So all these trials over the last several years, what we have learned that TAVR is now preferred, safe, and effective option for treating severe AS across the different, I would say, risk. So those risk, which is about when the patients are going for surgery, that's how the risk is calculated. So low risk, what we say, is less than 3. Anything more than 6 and 7, we call it high risk. So then the question comes for physicians and cardiologists like you, then who should be getting surgery? Okay, if most people can get TAVR. So that is what we are going to learn. So the most important question we face is, what is the life expectancy of the patient that you are seeing? So if your life expectancy is more than 20 or less than 10, and then we figure out maybe what we should talk to the patient. So all the guidelines, the center stage right now is a heart team discussion. So heart team discussion includes interventional cardiologist, the cardiologist, or yourself, physician that's making, and more important is a patient. So you can say whatever you want to the patient, but patient makes the final decision. So these are the important factors that we need to take into consideration, which is very, very important, is the age. And that is what even the American guideline says, age 65, age 85. Above 85 favors TAVR, less than 65 favors surgery, because that's also the valve duration and life expectancy. In between is questionable. You can have a 78-year-old robust patient with few other severe coronary artery disease, may be a candidate for surgery. Then, of course, surgical risk, which we said, frailty, valve morphology. Most of the patients have tri-leaflet valve, but if they do have bicuspid aortic valve, which also I will go over, then you should consider maybe they favor SAVR. Then, like I said, the femoral access, right? With the access, 90 to 95% is femoral. For some reason, if femoral access is not feasible, and we do use carotid, direct aortic, and couple other, we should not. If that is the case, you should again go back and address this. Is this patient probably better served by surgery? Concomitant other valvular disease. Okay, so you have 3 valve disease, maybe better off going for surgery rather than percutaneous. And coronary artery disease, which we know you have 3 vessel left main, complex coronary artery disease. Now you have to take care of coronary artery disease, valve problem. Patient is 70, a good patient, maybe should go for surgery. And then other important factors, rare, but yes, you have aortopathy. Okay, patient has dilated aorta, can have septal hypertrophy, endocarditis, probably not. A young patient, for whatever reason, has a porcelain aorta. okay? Probably better off with the TAVR. So these are all the important factors that we take into consideration, but what is the important message here? Age, so less than 65, more than 80, less than 65 SAVR, more than 80 TAVR, in between heart team discussion, no matter what, heart team discussion is the key. And this is something everybody talks, and you will hear this over and over when you go to various meetings, that you think about the patient, which is the lifetime strategy for the patient with aortic valve disease. And more than 80, we know, you do TAVR, okay, sometimes they live over 10 years, so now at 90 they are back to us, maybe we do TAVR. Then you have a younger patient, that is what, the patient is young, not ready to retire, but he does not want 4 to 5 weeks off from his job and says, no, I'm not going for surgery at this time, okay, I want TAVR, so do TAVR. Maybe he lives another 10 years. What should you do now? Do we do a TAVR in TAVR, or do we consider SAVR? So at that time, if he's a good candidate, maybe he can go for SAVR, lives another 10 years. Okay, then we again do another TAVR. So these kind of discussion need to happen with the patient, and patient makes the decision in these kind of cases. Despite all the guidelines and what I have shown you, what happens in the real world. So this is what TAVR versus SAVR guideline, which you see here, over 6,000 patients across here in the United States, what you see. Less than 65 years of age. Half of the patients of the TAVR are less than 65 years of age. And maybe the reason that I'm trying to tell you is the same, that patient decides, I do not want, because, I'm not thinking of living another 20, 30 years, just give me the easy procedure and be done with it. So less likely to have bicuspid aortic valve disease, but more important reason is they want easy procedure, go home early, and then definitely probably they might have had a CABG before. This is another thing that's happening with the, pressed button early, that what is happening in the real world, about over 100,000 procedures, and right now we have another valve that has been approved by the FDA. Now going to bicuspid, right? Why bicuspid is so important? So there are various kind of bicuspid, type 0, 1, 2. So it could be a single raphe or double raphe. That's how we call bicuspid. But more important is it just a single raphe, or is it the calcium that is on top of this bicuspid? A simple small registry showed that a simple bicuspid, it is comparable to surgery. Okay, that doesn't mean that you take every bicuspid and say, okay, we can do TAVR. So this is another study based on valve morphology and outcome on bicuspid valve. So if you see that, right, you see the calcium, so mild calcium, single raphe, okay, maybe that patient can do better with TAVR. But if you see the third group, which is calcified raphe plus excess leaflet calcification, that is the worst group, and look at the outcome, all-cause mortality, about almost 25%. So if you see a patient like that, you got to be very clear that your outcome is poor and discuss surgery with that kind of a patient. So that is why when we see bicuspid, again, heart team, and be very cautious, give all the data out to the patient, and then patients can make the decision. So this is a subgroup analysis of one of the trial which compared TAVR versus surgery. So overall, the group did very well, but when they did a subgroup analysis, which was a small number of patients, about 50 patients who had bicuspid, again, why bicuspid don't do well with the TAVR? Because you see the CT scan showing a lot of calcium right around here, okay? So if that's the case, you will have lot of paravalvular leak, that is one. And two, for whatever reason, there is disabling stroke, because when we are doing the valve and probably a BAV, that calcium probably gets dislodged, and there is CVA higher in this patient. So need to be discussed again with this patient. So if there is paravalvular leak and we think there is a paravalvular leak, should not go for surgery. So this is another, I would say from a registry data, not a randomized trial where they compared SAVR versus TAVR for bicuspid, look at the outcome, which showed that TAVR did poorly in bicuspid. Again, the conclusion was surgery remains better because of lower mortality in patients with bicuspid valve. Then comes what else is there. Like I showed you, if you have severe AS, we say if in echo your gradient of more than 40, which is mean, and can we do something for this patient before they become symptomatic? So the name was early TAVR. So before going there, there have been two randomized trials, which is comparing asymptomatic patients for surgery versus conservative treatment. So if you see there, conservative treatment definitely had higher incidence of all-cause death and other events that they happen in two trials that have recovered as well as AVATAR trial. This was just actually presented in TCT last year and came out in New England Journal early this year. Early TAVR, about 900 patients, close to 900 patients, randomized 1-to-1 of asymptomatic severe AS. And how did they know they're asymptomatic? They made the patient go on the treadmill about 6 minutes or so, no symptoms, no change in blood pressure, and they were randomized to either surveillance versus TAVR. So of course, if you see the overall outcome of death, stroke, unplanned hospitalization, okay, we got to pay attention there, significantly, you cannot do clinical surveillance. That is what the message from here is. But if you go deeper down, okay, what exactly happened, and this is a little bit of criticism in this trial, that after a month, if you see there, the so-called the patients who were into clinical surveillance start getting not randomized, got TAVR. So if you see there, by about 24 months to 36 months, about 86% already got TAVR. So this was an open label, which means now the patient knows that I did not get the procedure, and severe AS, I think maybe start getting symptoms. That's one. So this was presented in ACC, a sub-analysis again. What exactly happened? Why did those clinical surveillance patients, why did they have to get TAVR? If you see that, what they did was they went deeper down and said what exactly happened when they delayed the AVR. What they call AVR is some kind of a treatment that they got, but majority of them get TAVR and are delayed only by 11 months or so. So if you see that 87% of the so-called patients who are in surveillance went into the aortic valve. So this is the key message for all the cardiologists out there. So if you have somebody asymptomatic, severe aortic stenosis, right? And now you say, I just want to watch because no symptoms. Guess what happens? Delayed AVR with acute valve syndrome. What acute valve syndrome means, there is urgent hospitalization for some kind of a symptom. Most often it is heart failure, about 14.9%. And that is why I think what we have learned from this trial, though we know the crossover was a lot of crossover, that even if they're asymptomatic and severe AS, something has to be done. Do not, keep them, wait and watch. So this is another trial with AVR versus TAVR. And what this says is there some test we can do? What they did was MRI, checked for myocardial fibrosis. When they had myocardial fibrosis, they did poorly when they looked at it. So essentially saying, don't wait for myocardial fibrosis. You have severe AS. We are not saying that everybody should get MRI, but if they have severe AS, send them so that they can be evaluated. Next comes, I did mention about that if these patients are going for TAVR, should they be protected because there's a risk of stroke. So important trial, which was PROTECT-TAVI trial. If you look at the number of patients, over 7,000 patients, okay, half and half randomized. One to CEP, cerebral embolic protection device, okay. So a group got it, a group did not get it. And overall message is there was no difference, which is a disabling stroke versus even minor stroke. So routine use, so this is publication from New England Journal. Routine use of CEP did not decrease the incidence of stroke within 72 hours. So they used to be patients, we used to routinely do it. Now we are doing it only for high-risk patient. High-risk patient is patients already has a prior stroke, or they are a valve-in-valve because the risk of embolization is higher. Bicuspid, like I showed you, a lot of calcium. So these are the only group of cases that we will now do cerebral embolic protection device. This was a comparison. So protected TAVR was done here in America. BHF Protect TAVI was done in Europe. Combined both, and what did it show? Again, no difference, because the one protected TAVR did show that disabling stroke was slightly lower when you use CEP, but when they combined the data, there was no difference, and that is what it says though. Then is there some treatment for aortic regurgitation? So far we spoke about aortic stenosis. One trial that showed there is a valve that we can do, the valve that we normally do, because patients with aortic regurgitation do not have calcium. So why does the valve, we go there, we dilate it, but the valve stays there. Why does it stay? Because the calcium is used to anchor it. So in patients with aortic regurgitation, you can see that there's no calcium, so you need different kind of a valve which anchors into the leaflet or the annulus. So this is one trial said that it is feasible, it is a single arm, and it is doable. So it is it has been approved, but we are doing it very cautiously. Then question comes, patient has had prior surgery, right, valve surgery, and can they get, when there is a restenosis of this valve or there's progression into aortic stenosis, can this prior surgical valve get a TAVR? So it's called as valve-in-valve. So we have to be, I'm being cautious is there's a valve-in-valve, which is surgical valve, and now there is TAV-in-TAV. Means the patients are over 10 years of the TAVR, because we started in 2011. If they have survived, they're coming back. So that is, they are called TAV-in-TAV. So that is also being done. So if you see here, SAPIEN valve, earlier used to be X3, but now we call them S3. They have been done in, it is called as a valve-in-valve registry, and it has been approved that we can use, okay, the TAVR valve in prior surgical valve. Other question always comes is asked by the patients, family members, and the referring doctors. Okay, what do we tell the patient? Because if they are seeing a cardiothoracic surgeon, they will say, okay, we have been doing this procedure for over 40 years, and we have a good track record of having the durability of the surgical valve for over 10 years. They usually say 10 to 12 years. So when they ask that the question to us, we are like, okay, we used to say 6 years, 7 years and all that, but now we have a data, the NOTION trial, where they compared SAVR to TAVR, and you can see that both valve degeneration there was no difference. So we can tell the patients, yes, it can last after 10 years when they come and see you in your office. Moving on to mitral valves, which is what you know is the primary MR and secondary MR. So primary is about, I would say, 1/3 and 2/3, like you see there. And primary MR mostly surgery, is the secondary MR functional, where we know where the clip can work. So what does the guideline say? For primary MR, first and foremost, you have to see what is a surgical risk. Unless they are prohibitive or high risk, they cannot be referred or cannot have what is called as a percutaneous treatment with a clip, which was approved in 2013. In secondary MR, where we see there is a dilated LV or dilated atria, for whatever reason they are having this mitral regurgitation. Again, first and foremost is a fantastic 4. You got to make sure they are on good medical therapy, which is not just diuretics is usually for symptoms, but all the other medications they have to be on, and the EF is low. So we were part of the trial which I'm going to show, co-op trial. It was not easy to randomize, because as soon as you start the medication, patients feel better and the MR used to decrease. So you need to have moderate to severe mitral regurgitation on good GDMT. So even the CMS now says that you need a heart failure doctor to see this patient, but many of you who are here are excellent cardiologists. By the time you send the patients to us, they are on good medical therapy. And if that's so, and we still see mitral regurgitation, one test they need to get is a TE. And after that, if we know that these patients are, that we can do the clip and they're suitable, then we proceed with the clip. So the trial that I just mentioned, one of them was done, the COAPT first trial that was done here in America, mitral FR was done in USA, but both had two different results. There's important reason for it. So if you see here, the primary endpoint was hospitalization for heart failure, definitely a significant decrease in COAPT, no change in mitral FR. And the secondary and the first, I would say the only important trial that showed a benefit of death, okay, was in the COAPT. That means after you did GDMT, the big difference between mitral FR and COAPT was all comers were enrolled in mitral FR. They got the clip, then they went into GDMT. Compared to COAPT was different. You had to do GDMT and then they got the clip. So that is why we think they did better off. Means we were very selective who got the clip, and we will also show you the reason why. Then they repeated another trial in Europe, which was Reshape, where they used 3+ and 4+ MR. Here, there was no death, no difference in death, but the combined of recurrent heart failure and CV death was better because now they did the trial on medication. With all these three trials on board, guidelines have changed now. So if you see here, the biggest difference, the US, if you see the ERO, which more important is LVEDP per ml. Look at the mitral FR, LVEDP per ml, 250, which means it's a very dilated heart, compared to Reshape is in between COAPT. Essentially, we are trying to say is that COAPT was a very strict trial to enroll patients. And I think if you want to take home message is here. What does a COAPT trial show? If you see, it's called as disproportionate mitral regurgitation. The meaning is that you have LVEDP in the bottom. So when your EDP, diastolic volume, not EDP, end diastolic volume in the bottom, so it has to be, mitral regurgitation is disproportionate to what the volume is, telling that it is real compared to Reshape and mitral FR. Other meaning, simple meaning is do not wait too long, okay? When you see that there is LV dysfunction and there is moderate to severe mitral regurgitation, you have started them on therapy, but they need to be referred to a tertiary center for evaluation for whether they are a candidate for mitral clip. That is the take-home message from this. Several trials are ongoing right now, okay, from low STS score. Look at the age of the patient, 65 years, and what are they comparing? Okay, they're comparing clip to surgical procedures. So in the next couple of years, we should have some results with that. Then comes, okay, we can do the clip. Can we place a valve in the mitral area? Is it possible? If you see there, guideline says it is doable, but look at the number of valves. The fact that you have several valves, what is it trying to tell us? That we don't know what we are doing. Each shape is different, everything is different. The reason for that is, these are the various other procedure that they're doing is, if you see the mitral valve, it is very complex, not as simple as aortic valve. You know, aortic valve tubular, you have 3 leaflets, calcium, we go there, we place the valve, we come out. But mitral valve is not that easy. What the biggest challenge we face that when you place a valve in the mitral area, it causes what is called as a neo-LVOT. It creates a new outflow tract, and that outflow tract can now create gradient into the aortic valve. So that is why you see there are various shapes. We have tried various different shapes. None of them is functional. Other thing is, how are we going to get this bulky valve into the mitral area? Okay, we started with a transapical, which means you need a surgeon to give us an access. Like we said, when it is becoming cumbersome and too complicated, we interventionists do not want to get into that area. So now we're trying to do transeptal, but still have not figured out what shape and what size we can get there. So there is a one feasibility trial which has shown that yes, you can do it transseptal procedure. And other one that we just mentioned was that if patient already has a mitral valve surgery done in the past, can we use the so-called aortic valve in the mitral position? And yes, that can be done, and that is only done with the balloon expandable valve, which is the SAPIEN valve, and that also has been currently approved, and we do that procedure. Moving on to tricuspid, which is again like the clip for mitral. Can we get a clip for tricuspid? So what is interesting of a tricuspid? So if you see here, as people age, if you at the age of 75, you combine AS, AR, MS, MR, okay? Together it is one, but TR is prevalence is very high. And it used to be, say, called as a forgotten valve, untreated valve, because when we actually used to see the patient, I'm saying like 10 years ago, severe TR, what can you do? Nothing, just give Lasix, and that's what we used to do. But more important also, you see that is the surgical options. People don't like to treat, don't like to take them for surgery. Outcomes are very poor. The mortality is 8 to 10%, which we will show. So very few patients get treated. The question is, can something to be done to them? So again, going back, common cause for TR is secondary, because there is something happening on the left side of the heart, pulmonary hypertension, and you have TR. So often we take care of the left side of the heart, whether it is mitral or aortic, and we hope TR gets better. Primary is very rare, and that's what you see. Again, tricuspid anatomy is very complex. Why is it complex? The atrioventricular node is right there, okay? And you have 3 leaflets. Mitral was way easy, 2 leaflets. Anterior, posterior, clip 1, 2 would be easier. This is not that easy, number 1. Number 2, the imaging of tricuspid also is very hard. You need imaging, so the imaging can be done by either TE, or sometimes we use a small catheter through the groin and do it. But either way, but why we need to know this AV nodal? Because the need for pacemaker is very high, and that is what the even the trials have shown that. So the guidelines are saying that if you have TR, especially when you are doing left-sided surgery, take care of it. TR with symptoms, surgery. So every time there is surgery, surgery, and surgery. That is what it is happening. But if there is a TR and, same, if they have a high risk, if they have symptoms on treatment. Now the treatment is what? Most often these patients do have LV dysfunction. They have other concomitant disease. So they got to go on the GDMT for the left-sided. So you do that, give Lasix, still have symptoms, then clip can be done. So if you see here, again, surgical treatment are several. Transcatheter also. Several have been tried, but what have only made to the market is the clip, exactly what the clip that we showed for the mitral, but they've created slightly different for tricuspid area. And the other one that got approved was the valve, which is called the Evoke. We will show it. And this is why I think it's important that percutaneous treatment is better, because look at the surgical mortality, almost 8.89% or so. So we were part of this trial called Triluminate, where the first that was presented in 2023 was a small group of 350 patients, 1-to-1 randomization of medical therapy versus TriClip. So if you see that, device group and control group. So in the device group, significant reduction of the TR, but when they did the paired analysis and at follow-up at 30 days is same thing. The device group, it was only mild or trace MR, which is the green, okay? So they remained that way. So they did do fancy analysis, we call it, which is the win ratio, which is a combination of multiple outcomes. And that was positive. But the only thing in this trial, because most often what do you think for recurrent heart failure admission, that was not different. What was different was the KCCQ, which is you usually ask the patient the questionnaire, are you feeling better? That was the only different. And this actually, the full cohort was presented by Gilbert Tang and came out in the trial that 2 years follow-up, what did it show? Decreased rate of heart failure. So it's probably taking a longer time to show the benefit. Now it is showing at 2 years there is a decreased rate of heart failure admissions to the hospital. Then we are going to the valve replacement, which was again, which is the TRISCEND trial. That is what we are going to present. Now, why this is important? Because when you see these patients in the office, most often these patients who come with tricuspid regurgitation, look at that, 90% of them already have atrial fibrillation. Majority of them already have a pacemaker. So could this tricuspid regurgitation be related because of the pacemaker wire? So that is what happens with that. Like I showed you, the anatomy wise, about 17% of the patients required new pacemaker after doing the valve in the tricuspid area. That is what it is. And the most important is that majority of this patient had to go home on anticoagulation. If they were AFib, they're already on anticoagulation, they'll continue anticoagulation. Suppose that 5% of the patients who were not on anticoagulation need to be on anticoagulation at least for a couple of months, just because it is a low pressure side, which is on the right side. That's important. This is what I was talking about, the win ratio. That is, it's a complicated statistics, and this is now being used in many of the trials because they include too many variables all the way down, which is also included 6-minute distance test. So what did it show? That patients, they did better, but more important was just functional than what they found was the quality of life. So not hardened, okay, hardened point did not change. So TTVR was superior to medical therapy alone, improvement in symptoms and quality of life. So maybe we have to wait a little longer to see if they really had any difference. Now the question, often you will ask me, before I get the question there, who should get a TR or TTVR? So that is all based on echo. What is the leaflet gap, cooptation, the size, the length, the size of the RV, and the one thing about TTVR, if we think they are not clip patient and we think that they are going to get a valve, they need to get a CT scan. So we understand that this valve, we are able to navigate into the RV, and same that RV, it may not be challenging. Suppose they have a pacemaker lead, we may want it extracted, but otherwise we will exclude it. In that situation, we need an EP doctor with us to do an immediate pacemaker at that time if they need it. Otherwise, the need for the pacemaker, which we showed you, also is very high. Several other trials are ongoing for that reason. Next one is, if they have concomitant coronary artery disease, what will you do? Okay, so this is very important. That one trial which showed, you saw patients with aortic stenosis and now they have disease. So if you do 50 to 90% lesion, they had FFR guided. FFR is you check the pressure gradient across the lesion, and then had TAVR, versus they went for aortic valve replacement and bypass surgery. Guess what? The people actually did better when they got FFR with TAVI. There was another subgroup analysis of a Notion 3 trial, which was completely FFR guided PCI versus conservative management, right? And of course, patients who got FFR guided PCI during TAVR did better. So if you see that, what did they do overall, which is MACE, and the next one was MI and urgent revascularization. I think we always win for urgent revascularization, that if you have taken care of a lesion, they do not come back with the symptoms. The study that is ongoing, which we are part of this study, is a complete TAVR study where patients have CAD, they undergo TAVR, then they go to get randomized to either getting PCI after TAVR, or we do medical therapy on these patients. And this is, it's not that easy to do coronary artery intervention after having TAVR. That is why we have an app which tells us how to engage and do the PCI. Then the final is what are the new guidelines that we have in management of valvular heart disease that just came out from ESC. So like I mentioned earlier, and we are going again back to the same thing, the center stage is what? That you have to have a heart team discussion. That's what everybody talks about. That is a heart team discussion, and patient is the one that finally making the decision. And then you need to patient-centered evaluation for the treatment. And in the initial assessment, what you need to do is make sure you have the complete multimodality imaging that is included. So we went through this. So TAVR is class 1 for patients in America more than 65 years of age, and decision guided by detailed anatomic and clinical factors, which we have gone through with lifetime strategy formalized. Okay, so it has to be discussed with the patient, the lifetime management, which we went over. What is the lifetime management? For mitral regurgitation, they have made it class 1. We, in the United States, we are still not class 1, recommended for suitable, okay, that is secondary mitral regurgitation, whether it is atrial, ventricular. But ventricular is what they're talking about, that now they've divided it. In the past, we never had it. They've divided atrial versus ventricle, but let's concentrate only on ventricular, that you got to be on GDMT. And if you are on GDMT, that means you have to start on medication, still as mitral regurgitation. That becomes class 1 for us now. And if you have mitral valve disease and concomitant CAD, consider mitral valve surgery. That's the only thing. And a patient with aortic regurgitation, like we have said, it becomes class 2B, and TR now finally has got into that transcatheter therapy is finally making into the guidelines in there. So when patients are coming with for aortic stenosis evaluation, one thing we do say is we need to rule out coronary artery disease. So CCTA is now made into the guidelines as a class 1. If not, we still go with the invasive angiography, because what happens is they already need a CT for analysis of their valve. That CT versus coronary CTA is a different acquisition. So we cannot make them go through 2 CTAs. Instead, then if the CTA is positive, now they come back for angiography again. So what we do is just go for invasive coronary angiography, and look at what the guidelines are saying is class 2A. That if you have more than 90% coronary artery disease, class 2A to consider PCI before TAVR. And this is a very, very important topic, and I know I will have questions on this. After procedure, what do you do with this patient? Do we give only aspirin or aspirin with clopidogrel? So there are trials. This is popular TAVI cohort A, and if you see that, if you give both medication, we all know the bleeding risk is very high. But what happens to the ischemic risk? There was no difference. What it's trying to tell us is that you don't need 2 medications. Okay, so what we used to do and what we will do. Currently, you will see when the report comes, patients are getting aspirin, and we say give clopidogrel for 3 months if they don't have coronary artery disease. If they have coronary artery disease, they got a stent, of course they'll be on Plavix for a longer, maybe 6 months up to a year. Now the future, and you see the guidelines, we will show you that it's telling us only aspirin is good enough. And routine use of anticoagulation is not indicated, because there was a trial called Galileo which had to be stopped early because of the same bleeding risk. Then going to cohort B, the question comes, patient is on anticoagulation for whatever reason. Should we continue that, or do we add on top of that clopidogrel after aortic valve replacement? So same, you have anticoagulation for whatever reason, and now you add clopidogrel, bleeding risk is very high. So ischemic risk, no difference, slight difference. So what do we then say? You don't need to add another agent. That's why the current, that is, if you are on any kind of AC, which is a warfarin or any of those Novak, Dovax, you continue that. You don't need to add, okay, aspirin or clopidogrel. That is what the guidelines are saying. And clopidogrel is only needed, okay, if patient has CAD and intervention of the CAD with that patient got a stent, and now that also from 6 to 12 months. So guidelines has included that. You see that if you have TAVR, all you need is aspirin, okay, for 12 months. And for some reason, if the patient is on oral anticoagulation, you just need to continue that. You do not need to add any of the antiplatelet agents. Now going to after any kind of tear, like I said, if you have a mitral clip, it is up to, we do give Plavix for 3 months, aspirin Plavix, but there's no study to say so, but it's just a consensus statement. And TAVI we just mentioned. And for after, I would say tricuspid clip, they would definitely need anticoagulation. 90% of them are already on anticoagulation. We will continue. If they are not, 3 to 6 months, they will need anticoagulation with that. So what are the take-home message? TAVR is now preferred, safe, effective treatment for severe AS across all surgical risk group with expanding use in younger, lower risk, selected bicuspid patient. Very important, selected bicuspid patient. And MTR, both for degenerated and functional MR. But what you can see is that in functional MR, the surgical treatment ongoing, but in functional MR, very important is they have to be in GDMT, then we do it. So what TER and TTVR is less invasive for a tricuspid, effective options for severe TR, improving symptoms and quality of life. So depending on the anatomy, we will decide whether the patient will get a clip versus the valve. Antithrombotic therapy we went through very well, and I think guidelines are there, and our job is that guidelines are there to guide us, and more important is when the patients are referred, heart team discussion, multimodality imaging, and then we do what is right for the patient. Thank you for your attention.
Fantastic. Very detailed description of various advances. So there are a few questions, starting with, what strategies or optimization could reduce pacemaker implantation rates after TTVR, and have CT analysis identify related factors?
Yeah, so very, very interesting point. When we are doing TAVR, which I did not, because I don't think you'll have a whole day session of just structural. For TAVR cases, also there's a risk of pacemaker, used to be very, around 10%. We are now down to 6-7%. So there's a technique, okay? You look at the EKG, whether they have right bundle, left bundle, or incomplete. That will tell us the need of whether they'll require pacemaker or no. If there's a lot of calcium, we try, like you see here, the bundle of his and your, those pathways are very close to where we are placing the aortic valve. So we try to place the valve higher than what we need to do. So we will be very cautious when we are placing the valve. We need to pace the patient so blood pressure becomes low. We take a lot of precautions. But when we are doing tricuspid, as much as we want, it is not that easy, because the procedure itself is imaging guided, and the way the valve is placed, there's very little precautions we can take to decrease the need for pacemaker in tricuspid.
And majority of them already have a pacemaker of the tricuspid when we are
About
working
40%, yeah.
And then high incidence. So nothing has been done for the tricuspid point of view. Then would you recommend TAVR in asymptomatic low flow, low gradient patient as well, or only in asymptomatic high gradient AS?
Those trials were for a high gradient patient, because low flow, low gradient is another different symposium, I would say. Various, it all goes how you elicit the symptoms, and how the LV is, the output is. So all this, so far we have data, is mostly for high gradient patients.
Yeah, so all it required that the velocity was more than 4 meter per square to be enrolled both in the surgical trials as well as the TAVR trial of the asymptomatic aortic stenosis. Then the last question is, what about use of SGLT2 inhibitors and other agents for preventing progression of aortic stenosis?
I mean, based on the mechanism of action, I don't think that they can prevent aortic stenosis, progression of aortic stenosis. We know how this is, take out rheumatic. If it is just based on the age and how the wear and tear happens, it's mostly calcified, right? So statins have been tried with no difference, though, I do recommend patients to be on statin thinking it may help, but no study itself, but I think there are trials that are being there for this, try these medications.
Okay. Then last question here is, how much calcium does a patient need so that the TAVR can be safely performed without the risk that it displaces? Is there a cutoff of the calcium score?
Not really, but the grading of severe is based on the amount of calcium that is there. So 1200 to 1500, so that's a cutoff rate. But we have, as long as the valve, many times we see calcium and you give a number of 100, 200, that's the number we get when they go giving the CT scan. But the valve is thickened, okay? And very rarely you have thick valves, very little calcium, and that is doable. But it is not the same when it is aortic regurgitation, because most often the valves are not thickened and regurgitation mechanism is totally different. That is why you need a special kind of a valve when you are taking care of aortic regurgitation.
And actually the last question is very much focused on you. Are we using data for machine learning algorithm in this structural space? If yes, how is it impacting?
Yeah, so we actually did it. We presented it in Euro PCR last year. That how do you do? Nobody asked me that question. How do you select the valve? Who should get a balloon expandable and who should get a self-expanding valve? So right now, like we talk about, that subject was never touched, is experience of the operator, experience of the physician, and then we say this is probably the right thing. There are certain guidelines. So we actually put all the data we had, depending on the valve selection, and we came up with a model saying that the valve selection can be done. So right now, I know during the talk, nothing was discussed on can we use machine learning and any of these artificial intelligence models for clinical outcomes. Not yet, okay? Because the way we have to do is you have to first train those model to know what the physician knows. Okay, they got to come to our level. Once that is done, maybe then we can use that model to say, can they be better than the physicians? So it's a long way to go, but I think just like it was discussed, Dr. Mehran mentioned, ACC is all over it. And we in Mount Sinai, myself have a lot of interest in this. We have a lot of innovation, our own research lab that we are using these machine learning models. So more to come. Maybe next year we will tell you a few other things.
And actually there is another very interesting provocative question that once the LP little a therapies are approved, will the aortic stenosis will be eliminated?
We need a crystal ball in front of us.
The statin didn't work?
LP little a, let us work on coronary artery disease first before we go to aortic stenosis.
Yeah, so SGL2 receptors did show that post-TAVR, after you started it did help. Recent paper just came out that decreased overall event rate, post-TAVR events were decreased, just like diabetic patient, post-MI patient, same thing in the TAVR group also. But whether pre will do, I am not aware of any
trials
starting pre, reducing any changes. If anyone other expert here, Roxana, Deepak also.
Huh?
Yeah. In the pre.
LP little a trials for pre-TAVR.
I don't think we're gonna cure aortic stenosis with just LP little a.
Maybe the CAD.
That's
maybe
what I meant. Let's focus on LP little a and
maybe
CAD.
We can cure control the CAD. All right, with that note, fantastic. We are about half hour late. You will ask him, but I think we'll be good. Okay, get ready. And those who have shown that tolerance, as you see, things just came. One of you will go home with the nice, what is that? iPad, which will be taken up.
The final slide was our symposium. We forgot.
Which symposium now? Gone.
Huh?
Yeah. Oh, yeah, we have. the valve symposium.
Yeah. One
Okay.
second, guys.
All
Can you
right.
go back to my slides? I mean, many people here would love to attend that.
it outside, right? They have this, outside they have it. The valve symposium.
No, they have?
Everybody come to the valve symposium.
No. Yeah. Go back and show the last slide. Oh, yes. Oh, yeah. Right there.
It's a very special day
Yeah.
that day.
Yeah. Very special day. Kiski made sure everybody knows.
Not forget December 11th and October 17th.
Happy birthday to Dr. Mehran today. I don't know how it happened. Today is her birthday, December 11th is my birthday. So that is why I make sure everybody comes.
Okay. All right, so let's